Hi, this is a very quick talk on PrEP and renal monitoring done for the health advisors. So I've tried to keep it really simple and hopefully explain some of the rationale around the monitoring. So PrEP is a highly effective strategy to prevent HIV transmission, and the best studies are done in men who have sex with men and transgender women. So you can see that if you look at the results of IPREX overall, the reduced risk of HIV was 44%. But if you then looked at the number of people who took at least 2 or 3 pills a week, that reduction in HIV risk was then 84%. And then with an open label extension of IPREX, they showed that men and transgender women taking at least 4 or more pills per week had 100% reduction in their HIV risk. That was a placebo-controlled trial. In real life studies, of course, the risk is slightly less because people don't take their tablets properly. So in both IPERGAY and PROUD, there was an 86% reduction in HIV transmission in those men who were using HIV PrEP, either daily or event-based. And the 14% of people who acquired HIV was because they weren't taking their tablets properly or at all. So there are 2 problems with PrEP. First of all, they are a group of men with very high rates of STIs, and we're seeing more and more men using having condomless anal sex associated with PrEP. And this is Colley's data from a few years ago showing that in Brighton, MSM using PrEP have significantly higher rates of syphilis, gonorrhea and chlamydia compared to men not using PrEP. And this is a more sophisticated study from Australia where they were able to define STI rates in MSM and transgender women in South Australia and in Victoria before they took PrEP. And then they took at least 1.1 years of PrEP as part of a study similar to our impact study, and they showed that the increase in STIs in men who start PrEP is actually only 12%. And of those men, it's a very small group of people who are actually acquiring STIs, suggesting that sexual behaviour only changes in a small group of MSM. And the message shouldn't be to demonise MSM using PrEP, but to make sure that we're monitoring them and testing them and treating them for their STIs. So what about kidney monitoring? So tenofovir is the main component of PrEP that's doing most of the work. The other component is emtricitabine. And tenofovir is the drug that we need to focus on in terms of monitoring. So tenofovir is metabolized and excreted in the kidney, in the proximal renal tubule. So the tenofovir is broken down in the kidney and then we pee it out. And under normal circumstances, healthy individuals will do this with no problems whatsoever. However, in a very small proportion of people, the tenofovir can actually cause disease in the kidney, and it causes inflammation and dysfunction of the proximal tubule. So this diagram is a single kidney unit where blood is filtered in the glomerulus, and it forms this fluid which then goes through this very complex network of tubules where protein and minerals are absorbed and reabsorbed back into the blood, and the resultant is urine, which is full of all the toxic stuff that we don't want. And tenofovir is metabolized in this system, but in a very small proportion of people can cause disease in this system. And the disease that it causes is called Fanconi's syndrome. So Fanconi's syndrome causes 2 problems. First of all, it causes our urine to become high in protein, glucose, phosphate and calcium, because it's that part of the kidney that reabsorbs those minerals. And if you've got Fanconi's syndrome, you can't reabsorb them, so you pee them all out. So you're peeing out protein, glucose, phosphate and calcium. The other thing that happens is that the glomerulus stops working properly, so our ability to filter our blood reduces, and we can monitor that using the creatinine. So there's two ways of detecting Fanconi syndrome. First of all, looking for those things in the urine that are metabolized in the proximal tubule, which is protein, glucose, phosphate and calcium. And secondly, by measuring the creatinine in the blood, which you can then work out the filtration rate. It's really important to understand, however, that in Fanconi syndrome, the first thing that happens is that we pee out protein, glucose, phosphate and calcium. That happens several weeks, if not months, before we get a reduction in our kidney's ability to filter blood. So, monitoring for Fanconi syndrome, so looking for Fanconi syndrome, we do by two different ways. First of all, looking for protein in the urine, and we do this using a test called a urine protein creatinine ratio, and this should be less than 35. If it's more than 35, it means that this person has got protein in the urine and it could be due to tenofovir or Fanconi syndrome. The second thing we do is we monitor kidney function. And we do this for two reasons. First of all, to see whether or not the tenofovir is causing kidney disease, but also to make sure that patients haven't got pre-existing kidney disease or something else that's causing kidney problems that might increase their risk of getting tenofovir toxicity. So we measure the creatinine in the blood, and then we're able to calculate from the creatinine the filtration rate, and the laboratory already do that automatically for us, and they do that using this thing called an estimated glomerular filtration rate, or EGFR, and it should be more than 60. So fortunately, our electronic patient record has this all in the PrEP tab on the EPR. So you can see here this patient has had the creatinine done, the urine protein creatinine ratio, and the EGFR has been calculated for us. And here this man's always had a normal urine protein creatinine ratio. It's always been less than 35, and the EGFR is always more than 60. So Fanconi syndrome is very rare. It's really rare in people who are HIV negative. The risks of getting Fanconi syndrome are age, particularly being over the age of 40, taking nephrotoxic drugs, having high blood pressure, and having some other sort of kidney disease. So they're the things to watch out for. So in terms of monitoring patients on PrEP, we should be doing regular STI testing because of what I showed you earlier, and of course HIV testing, and we should be doing some renal monitoring using a urine protein creatinine ratio and a creatinine. And if those things become abnormal, obviously you need to talk to a doctor because this can be quite complex, and the options are that we stop PrEP, or we can think about using PrEP on an event-based dosing regimen which reduces their toxicity. There is a third option in the future, which is to use a slightly different salt of tenofovir called TAF, or tenofovir alafenamide, and that's brought together in a tablet called Descovy. It's currently not licensed for PrEP in the United Kingdom. It is in the US. It will come here eventually. So our UK PrEP monitoring guidelines are as follows, as I summarised in the handbook. If you're under 40 with no renal risks, you need a baseline creatinine UPCR. It's useful to do a weight in case I have to calculate a filtration rate based on their weight, and then a yearly creatinine if they've got a normal baseline. If they're over 40 and or they've got a renal risk, which actually is a lot of our patients on PrEP, they need baseline renal monitoring and then 6 monthly creatinine and UPCR. And just to remember that risks are nephrotoxic drugs, hypertension and renal disease. There may be certain circumstances where I'm particularly concerned about them getting renal disease from their PrEP, and I might request a more frequent urine protein creatinine ratio and creatinine. So that's my summary of monitoring in patients on PrEP, particularly with respect to kidney disease, and I hope that was useful.